Well, good afternoon. I think we'll go ahead and get started. My name is David Holtgrave. I chair the Department of Health, Behavior, and Society. And on behalf of Shannon Frederoli and myself, who co-direct the Center for Implementation Research, we're really excited to have this kickoff to the speaker series today. We have a tremendous speaker, and we couldn't be more pleased. So I wanted to welcome you to the session and also to thank not only Center for Implementation Research, but the Center for AIDS Research, very especially the Dean's Office and the Department of Health, Behavior, and Society who co-sponsored this event today. It's been really an exciting time, I think, over the last several months in the school to talk about implementation research. There's a new course that many of you either participated in or took or helped to teach in implementation science. Soon we hope to have a certificate program in implementation research and a speaker series which we're kicking off today, which we're thrilled about. I would like also to thank Dean Clegg. He's been tremendously supportive of the work in this area of implementation science and implementation research, convening the groups to come together and talk about this across all of the departments, and also helping to support the speaker series, both with time of staff and also financially supporting the speaker series. And with that, I'd like to ask Dean Clegg if you'd be willing to come and introduce Dean Fixsen, please. Thanks.
Well, it's easy to be supportive of implementation research, right? It's so critical to what we do and having an impact. So I'm very happy I can be here today. But I introduced our speaker with some trepidation. So we have a general policy in the school that I, as dean, never invite anybody named dean to give a talk, because then it devolves into this debate: who's the original dean, who's the real dean? But our speaker is so accomplished, we had to violate that rule. So it's my pleasure to welcome Dean L. Fixsen, who's here today to speak to us. And he asked me to give a short introduction because the longer introduction would eat into his time. But I would say that, on reading about him and getting to know him, that his career really was started through a passion to make the world a better place. In 1963, he was a psychiatric aide, and then from there went and developed and got a PhD in experimental psychology from the University of Kansas. And he has really spent his career developing and implementing evidence-based programs, initiating and making changes and change processes in provider organizations and service delivery systems, and working to improve the lives, especially of children, but of adults as well. So I'll just go through a little bit of his background so you can have a better purchase on what he's going to tell us. So he is, in Kansas, he was co-director of the research group that introduced the teaching family model, which is an early version of an evidence-based program. It was 45 years ago, remember, and one of the few that has national certification standards for practitioners and for organizations using the model. He's co-author of the highly regarded monograph, Implementation Research, a synthesis of the literature, long day here, and he served on numerous editorial boards and advised federal, state, and local governments. We're talking to him about his career earlier. He's been in a number of places, and it came up in conversation that he is actually a dual citizen of the U.S. and Canada, and worked in Calgary for 15 years, was at University of South Florida, and now is at UNC, where he's senior scientist at the Frank Porter Graham Child Development Institute at UNC at Chapel Hill. He co-directs the National Implementation Research Network. He co-directs the State Implementation and Scaling Up of Evidence-Based Practices Center, and he's co-founder of the Global Implementation Initiative, and he's a member of the Board of Editors of the journal Implementation Science, which he helped found. So, as I said before, he's spent his career developing and implementing evidence-based programs, and is going to talk to us today and give us his advice as we see how we best structure our efforts in this area. So, Dean, thank you very much for coming.
Thank you very much. And just to be clear, I've been a dean longer than anybody else in the room. So, but it's truly an honor to be here. The invitation came, and it was one of those times where you just say, "This is something I want to do." So, and anything to just support the kind of beginnings of the center that you're creating here at Johns Hopkins. We're happy to do. So anyway, we want to I want to give you a bird's eye view of implementation science, practice, and really a compilation of a lot of the literature that we have been looking at now for many, many years. So I can tell I'm in a medical place, right, when we talk about livers as opposed to literature. So first thing, and we'll share a few lessons along the way, but we'll have this kind of built in. But the first thing is there is now sufficient information to say that we have a science of implementation. 10 years ago, this was not so apparent. Find the right buttons here. Did a quick search at the UNC library over the weekend. From 1900 to 2005, you can see that there were 7,790 references that showed up when I plugged in implementation science. When I put in implementation research, the number was 2,563. But look what happened in the last 8 years. Those numbers have doubled. So to say that this is a science that is finding its way, and whose time has come, I think we have some evidence to support that. We have now gone from making lists to making sense of things. When we did the summary of the literature back in 2005, I was sick to death of reading one publication after another that lists, here are the facilitators, here are the barriers. You read another one, you find lists on lists on lists. Well, now we're starting to take those lists and make sense of them. And thank goodness we are there. So we have the frameworks that evolved out of the review of the literature that we did. Myers, Durlock, Wandersman summarized 25 frameworks and implementation, did a nice comparison of those. Tabak and colleagues recently had a broader view where they're looking at dissemination and diffusion along with implementation. The numbers there, diffusion, there were 11 theories that were specific more or less to that, 33 for dissemination, 17 for implementation. But now we have people who are making sense out of the literature. They're helping us to go from making these lists to figuring out what it is that's really important about this and how we should be paying attention to it. Here's a formula for success. If we want to boil all this vast literature down to a few things to really pay attention to, and this is for any field, anything that you're doing in health, anything you're doing in public health, anything in mental health, substance abuse, bridge building, banking, we find these things coming up again and again and again. So we think implementation is a lot like gravity. It's universal, it's always there, always working, whether we choose to pay attention to it or not. But in the formula for success, there are three things that really need to have our attention. We need to do research on these things, and we need to use these to guide the work that we're doing. By the way, all of these slides I will get on a PDF and send back, and you can have it on your website or in distribution lists here. I would have done that earlier, except I didn't finish it until this morning. So, but effective interventions, we need to know that what we are investing in is actually worthwhile. If we do this and we do it well and we spend a lot of time attempting to do it, that we are likely going to get a socially significant outcome from having done it. But that is insufficient. Lots of evidence now that says knowing what to do is a nice place to start. Knowing how to do it, which is the implementation part, that is a critical and missing piece. So we'll talk more about those. Enabling context. Here's where sustainability, here's where scale comes into play. Okay, we have the effective intervention. We are doing this really, really well. And so far, we have created islands of excellence that are there for a while in a school district, in a hospital, in a clinic somewhere, in a country. But without the enabling context there, without the supportive policy and funding, and we were talking earlier about how people write RFPs, all of those things really matter for sustainability and for scale up. But when we have all three of these things working together, and notice that they do need to work together, this is a multiplication problem. And we know that if we don't have any one of those three factors, anything times 0 is 0. That's right. I knew I was in the right crowd. You guys know the answers to these questions. So if implementation is weak, we could have the other two. We could have extremely effective interventions, enabling context, but we're still not going to get the outcomes that we want. We could do effective implementation of ineffective interventions and enable those, and we're still not going to get the outcomes that we want. All three of these things are equally important, and we need to find out more about them. But keep this formula in mind, and we'll have many reminders here as we go along. What we have facing us in human services generally, globally, is an implementation gap. It's that middle part that is we have not attended to, and as we just saw in the literature, until 10 years ago, we didn't even know what to attend to. It's only recently that we have come to this knowledge. But interventions are not used as intended. They're not used to produce the good outcomes that we see in studies. They're not sustained for any useful period of time, and they're not sufficiently used at scale to actually produce the population benefits that we would like to see. So let's take these things one at a time. I'm realizing that this is going quickly. Hopefully we'll have a few minutes at the end for a few questions, so write down a few of these. But the effective intervention, we always are asking ourselves, well, what is it that we're trying to do? So that is the question we're asking here. It is becoming more and more apparent that evidence of rigorous evidence is not enough. We also need to know what is the program. When you go to use evidence-based programs, you're not using the standards for rigorous evidence. It doesn't matter that the standard is how many randomized control trials done under what circumstances. That's not what you use in practice. What you use in practice is a program. It's a set of methods that you use in order to produce. So these innovations need to be teachable, they need to be learnable by typical people, they need to be doable in practice, and they also need to be accessible. So those are the four things that we are looking at for. But try to find definitions of programs. If you try to find definitions of what is the evidence for evidence-based, you'll find 1,000 examples of that. And I dare say you will find no more than a handful that actually define what is the program. As a matter of fact, people since 1991 with Monker and Prince, right through 2010, people have been summarizing outcome studies and looking at what is it that produced the results that we are pleased with when we look at the outcome studies. How many people actually assessed the independent variable that was described in the method section? Well, it turns out about 18% had any kind of an assessment to say that what is described in the method section actually was done in practice. And of those who did that, about 7%, still 7% of the 1,200, then used that assessment in an analysis of the outcome data. So that many of them assessed, some of them assessed the independent variable but didn't include it in the analysis. But also in 7% of the cases, and this trend has not changed much from 1991 to the Nalepa and Kegel work in 2010. We find about the same percentages time after time after time in these reviews. So only in 7% of the time do we know that if we do these core components of the intervention, we will more likely produce these outcomes that we're interested in. We need to define programs. So this has led us to look at usable intervention criteria. So we want to have a clear description of the program, philosophy, values, principles. Those things matter a lot when you're going into new settings. Do people believe what you're talking about? Do they agree with the philosophy behind it? If you have a highly behavioral program and you're walking into a crowd of psychodynamic psychiatrists, chances are you're not going to get very far because they're going to discount this right from the very beginning, and vice versa. So philosophy, values, principles really offers guidance for what to do. Inclusion, exclusion, who is this really designed to help? And those criteria, as important as they are, as obvious as they are not so clear in many of the studies. What are the essential functions? What are the core ingredients? What are the things that have to be there? You need flour, sugar, yeast. I mean, and if you leave any of those things out, you're not going to end up with, I don't know, whatever you make out of flour, sugar, and yeast. I'm not a cook, so. But anyway, these core components that we need to know what they are, and not only what they are, but how to do them. What do you do? What do you say when you're actually making use of those essential functions? Because that gets us into what we're going to be teaching people to do, what we're going to be assessing people to do. And the last thing on this list is a critical one as well. Is there a way, a practical way, of assessing performance in practice? And is that highly correlated with outcome? We put in the correlation of 0.7 just to generate conversation because we have yet to see more than maybe one or two evidence-based programs that are even approximating 0.7 in terms of if you do these things, which means that you can explain what 49% of the variance, right, with a 0.7. But we need really highly effective ways of measuring fidelity, and we'll come back to that as we go along. But these usable intervention criteria, they are very important from an implementation point of view. Effective implementation, so how are we going to do the work and who is going to be doing this work? Second lesson we want to talk about, passive approaches to implementation are not enough. Active, purposeful, skillful approaches are needed if we're really going to do this work, do it effectively and do it again and again. As we were doing the survey of the literature and the synthesis back in 2005, we found, much to our surprise, that the very best data, randomized control trials repeated in various fields, were all about things that didn't work. Diffusion, dissemination of information by itself, training by itself, passing laws, mandates, you can read the list. Over and over and over again, we found that if these things are done on their own, you realize 5 to 15% of the intended outcomes. So the other 80, 90% you will not get what you're looking for. So the best data we have are about things that don't work. But this is valuable. We tell people, we get all excited about really good data about things that don't work. Oh, a failure that we can document. Now we know what not to do again. Let's stop that. Let's do something else. Let's invest in a new thing. But these data are just repeatable, and again, looking back over the last 20 years, and there's only just 2 or 3 references here, but there are many more. This 5 to 15% seems to be kind of the baseline level. If you put stuff out there, 5 to 15% of folks somehow or the other, in spite of whatever is going on, will figure out how to make good use of it, at least for a while. Here's an example from education. Comprehensive school reforms. The federal government invested many millions of dollars in the research. All of these, there are 5 different reforms that were on the pick list for districts and schools to choose. But all of them had a strong evidence base. When the evidence was being developed during the research, you can see in the left-hand column, every teacher was trained to use the comprehensive school reform, and every teacher was continually supported. They had follow-up supervision and coaching. So when the researchers at evaluators at Rand Corporation then were commissioned to follow up on this set of reforms, these districts chose to do them. They got some funding to help them get it done in their districts and schools. But what happened in the first 3 years? This is one of the few studies that actually looked at implementation during the course of people trying to make use of an innovation. Fewer than half of the teachers actually received some training, not even all, and fewer than 25% of the teachers received any kind of follow-up help. Consequently, by the end of the evaluation, fewer than 10% of the schools, there's that 5 to 15% again, fewer than 10% of the schools used the comprehensive school reform as intended. Consequently, vast majority of students never experienced it. Here's 8,000 schools, $2 billion of our tax money went into this. But here's another bit of information that we celebrate. We now know that if, in fact, these are the conditions in the experimental original studies that produced it, we need to reproduce those conditions. We need to train teachers. We need to do the follow-up coaching and supervision if, in fact, we want to realize the benefit. Otherwise, what are we going to get? We're going to get the 5 to 15%. Implementation science. Here's a set of 3 categories of activities, Greenhall and others, Hall and Horde back when, and we picked up on this as well. But they said that there are 3, Greenhall, when they did their survey of the literature in 2004, they were looking at dissemination, diffusion literature primarily, but they said there are 3 categories of activities. There are the letting it happen approaches to implementation. We're going to publish it. We're going to put our information out there. It's up to you all to figure out, to read the stuff and to make use of it. Helping it happen, now we're going to have websites. We're going to have some one-shot training. We're going to we're going to put together nice brochures and ways to connect with people like you have done here. Just in case you don't know, this is yours. But we're going to help people understand this. We're going to proactively promote some of these ideas. Then there's the making it happen. This is mission driven. This is where we are going to be, and it's not making it happen in a heavy-handed way. It's making it happen in the active way. It's now not your responsibility to figure it out. It's our responsibility to help you do it. And so this shifts the accountability into implementation teams. But we're very much on the side of making it happen. All 3 of these things are very important, so not to take anything away from any of it, but it kind of culminates in the making it happen group of activities. So the work that we've been doing within the National Implementation Research Network and with our colleagues, the NIRN, the network part of that we take very seriously, and we have many, many colleagues all over the globe who are very, very helpful to us. But here are the things that really make a difference when you're doing active approaches to implementation. You're in that making it happen mode. Innovations, by definitions, are new ways of doing work. And if they are new ways of doing work for practitioners, for organizations, then people need to learn how to do this new way of work. And so that's where the competency drivers really come into play. This is helping people doing the professional development work, helping them learn the innovation so that they can do it with fidelity. Notice fidelity is at the top of that triangle. We also found, though, that learning how to do things differently at the practitioner level is a great place to start, critical, necessary, but it doesn't last very long. Sustainability is a real issue unless the organization itself changes to support practitioners doing these things in these new ways. So organizations need to change. The clinic, the hospital, the residential program, the school, the district, all of these need to change to support these new ways of work. Those are the organizational drivers. And of course, none of this is going to happen without leadership support. you're not going to get started, you're not going to get past the first set of issues that you bump into that require some change without leadership being there to be helpful. And of course, all of those things have lots of pieces and parts. So selection, training, coaching, performance assessment are really on the competency side. Decision support data systems, what data on what kinds of things are going to be very helpful, because you know that wherever you start is a good place to start, but it's not all that you need. You need to have improvement cycles built in. We'll touch on that in a second. But those improvement cycles are fed by the data. Facilitative administration, you need managers and directors who are looking for the next way to help practitioners do this new way of work better and better. How do we get out of their way? How do we shorten up meetings where we spend 90 minutes admiring the problem instead of 5 minutes talking about the problem and the other 85 minutes talking about how to solve the problem? I mean, there are lots of ways that administrators can use the time available differently. Systems intervention. Not everything that needs to be done to facilitate the work within an organization can be done within the organization. You interact with how you are accredited, how you're certified, how you're funded. There are the broader systems issues. But the worst thing is to have the clinic or the hospital or the county work going on, being frustrated by the system, but no one is saying to the system, here's the poor fit now between this new way of work and how the system itself functions. So the system it's a way of bringing this in. So here's a little bit of data. And Joyce and Showers did a massive review of and synthesis of the literature on training and professional development in education. And they found that when training and when teachers were selected and trained, and then you look a few years later, you saw just what we saw a minute ago, about 5% of those teachers actually used their new way of work in the classroom. With coaching, though, added to selection, training done well, now you're following up with the coaching, it went to 95%. Huge, huge difference. So what this means, though, from an implementation point of view, is that we can choose. What result would we like to see? We can invest in training alone and know that we're going to get 5, 10%, 15% maybe of the folks actually doing what we are training them to do. Or we can invest in training and coaching and know that we're going to get 80, 90% of the teachers or the practitioners doing what we would like them to do. That is a huge difference. But coaches routinely are not funded in human service systems. So we have supervision often, but we don't have coaching in the way that it's discussed here. So, but we can make a choice. Here's dialectical behavior therapy, DBT. Here, and they were working with folks who had substance abuse problems. And here with low fidelity use, they're getting about 30% clean urinalyses. With high fidelity use of DBT, they're getting about 80%. So same program, everybody's using DBT, right? These folks are using DBT as intended, getting 80%. These people are using DBT in a way that they are not happy with, and they are getting about 30% success. DBT started out in the 1990s, and they did a lot of one-shot training, the kind of training alone that we talked about for probably 8 or 10 years. Then we started talking more and more about implementation to the folks and pointed out that, well, fidelity seems to be an important thing. We have it up at the top of that triangle for a reason. And so they said, well, we'll go and see how people are doing with DBT. And so they went out and they went to some of the places where they had trained folks 3 years ago, 4 years ago, 5 years ago. They came back, and I just happened to be at the meeting when the folks came back and started reporting. They said, we don't have, out there in the field right now, we don't have dialectical behavior therapy, we have diabolical behavior therapy. They were not happy. So very soon after that, they developed their fidelity measure, and these are some of the early returns. Here's some data from Greg Ahrens. His hypothesis going into this was that, you know, all of this fidelity monitoring, training, you're really messing around in people's, practitioners' lives. They're not going to like this. And his prediction was that by having evidence-based program with a lot of monitoring and, you know, coaching and fidelity assessments going on, people would leave. And quite the opposite turned out to be the case. When you have all the things on the competency side of the triangle, selection, training, coaching, fidelity assessment going on, 53 or 58% of the clinicians in these settings in the state of Oklahoma is where this was done, stayed for 3 years or longer. When they had everything except the fidelity assessment, only 22% stayed 3 years or longer. And you can see the similar results for the treatment as usual groups. So not only do the competency drivers produce better results in terms of higher levels of fidelity and better outcomes for the individuals who are the recipients of the service, but the practitioners, these people that you've invested in for competency development, they also stay around longer. And no surprise, when they're talking to folks, who doesn't want to be effective? We're all in this field because we're do-gooders. We want to do good, right? And if you have fidelity, you have coaching, you have somebody to help you do good. If you have fidelity assessment, you have evidence that you are in fact doing the program as intended, that you're doing good in the way that you want. So there's a lot of positive feedback for practitioners based on using the competency drivers well. Here's a little bit on organization leadership drivers, data we collected years ago. We had a number of, and these were group homes, so residential treatment group homes in communities, residential community neighborhoods. And I don't know if anybody has tried to get a group home for delinquent kids in a residential neighborhood, but let me tell you, it takes a heck of a lot to get that home licensed and accepted by the neighbors, and you spend a year doing nothing but community entry and neighborhood entry. So as we were doing this work, we started noticing we are losing group homes as fast as we are creating them. And when we actually looked at the longevity data, how many of these homes actually stayed open for 6 years or longer? Only about 15%. Totally unacceptable. So this is where we started then looking at the leadership and the organizational side. No longer were we just going to be training practitioners, we're going to be training groups of practitioners in an organized unit. And so we still community-based, still in the neighborhood, still everything, except now there had to be 4 or more group homes, typically 6 or 7, that were there, so that the local organization was there to support it. And as you can see, for the next 219 of those, we had about 84% who were in business for 6 years or longer. A huge difference. So these are the hard-won lessons that kind of led us down this path, but it makes a difference. Lesson number 3, interaction-based innovations vary within practitioners over time and across practitioners. We have, so there's human beings, when they are interacting with each other, we influence one another. This is not like having a serum or a pill where the science is built into the chemical composition. Here, the science is being built into, if you will, a human being, a practitioner. But when they're doing this work, you are as influenced by your recipients of your service as you are influencing them. So we expect drift. We expect things to change over time. We don't expect that somehow or the other we're going to train people one time, coach them for a couple of months, and everything's going to be just fine. So in interaction-based innovations, we expect a lot of variability. And because of that, and I'm not going to spend a lot of time on this, but this is something, these improvement cycles are very, very important. There's now, and especially in your field in health, there's a whole field that's being created called improvement science, which is a lot like implementation science, except it has kind of a singular focus on these things. So we expect that there's going to be drift, we expect there's going to be change, we expect some of the changes are going to be positive, and we want to capitalize on that, and some things are not going to be so positive, and we want to have the problems go away. So these are trial and learning, not just trial and error, but trial and learning approaches to improvement. And some is rapid cycle, as you see. Some is usability testing, where you have slightly larger groups of people where you're trying things out, and the practice policy communication loop we will get to here in a minute. Lesson number 4, realizing impact of innovations consistently and on purpose requires active implementation. So to do this consistently, to do it on purpose, to do it again and again, we have to know what we're doing. Here's a little bit on implementation teams. Implementation teams are these skilled groups that know implementation science well, and we'll talk about that in a second. But if you have an effective intervention and you have an expert implementation team, you can get about 80% success in 3 years or so. But if without that, there's more and more data now mounting that you get about 14% success in 17 years. That's the letting it happen, helping it happen, where we put this stuff out there, up to you to figure it out. People have been trying to figure out implementation for a long, long time. That's what's over in the left-hand side of this. When implementation is done purposefully, it can be done repeatedly, and that gets us a better result. So implementation team, what is it? At least 3 people. We prefer 4 or 5. But this is the implementation capacity that's missing. But these are the folks that have expertise in how, those usable intervention criteria. How do you go about operationalizing an intervention? What are the steps involved in that? And Leah Bartley, who is here with me, and her colleagues have really put together a very nice package on how to operationalize innovations. But this takes work. Somebody has to be able to do that. Who is going to do the work? The answer is the implementation team. Implementation teams, of course, know implementation science and practice very well. They also understand about that organizational side. How do you change organizations? What are the implications of that for systems? The other reason that we emphasize implementation teams, right now there are implementation individuals out there in a region of a state or in a set of clinics. But what happens, and many of them are doing quite well as far as producing good outcomes, implementation outcomes, as well as innovation outcomes. But what happens when that one person leaves? All the memory, all the skill, everything walks out the door when she leaves. And so when you have 3 people, you have a chance of being self-sustaining. You can regenerate. One person leaves, 2 people are there to kind of pick up the slack, bring the new person in, keep things going. So sustainability, and there's now some very nice evidence of that actually from Klassen Patras over in Norway. So 3 or more. But implementation teams, the point here is these are skilled people. It was nice when I came in here today, we had our information technology team. They have all of this set up. They were showing me how to do this. You poke this little jobby here to make it go. And stand close to the microphone, don't move from the podium because of the visuals. And I mean, they were here to help me do this. They didn't just say, figure it out on your own. Important thing about implementation teams when it comes to making larger scale use of innovations. Everything we've talked about so far is over there in the gold color on the right-hand side, where implementation teams are using implementation principles to produce intended benefits. But the data say that from a variety of sources say that about 20% of individuals, 20% of organizations are actually ready for change at any point in time. So that's the pick me group. Who would like to go first? Well, pick me. So that's the 20% that's ready. But what about the other 80%? So right now, if we're trying to scale up something, we're going to be stuck with the 20%. Well, without an implementation team, what is our alternative? We sit back and wait for the other 80% to get ready, and in the meantime, the 20% we're working with probably start falling off the charts. So here we are churning around a mediocre mean. So implementation teams, part of their job is to help the other 80% get ready. What are the impediments? Going to talk to people, what's getting in the way? Are there rules, regulations, attitudes, thoughts, lack of information? But this is where the dissemination, diffusion parts of things really come into play. This getting ready involves a lot of that. So like I said before, all of these things fit together nicely. So creating readiness, though, is a major function of implementation team. This is the way you get from the group that you start with to demonstrate the value of all of this to actually getting it to scale. Implementation teams, the one thing that you will find repeated again and again in the implementation research and evaluation literature is this is a complex set of things, multiple layers, multiple functions within layers, and all of this is happening simultaneously. So what do you do about this? Well, for a long time, many of us started at the practitioner level, and when we got far enough along, then we started bumping into the organizational things. You saw the data earlier with the longevity data for the group homes. There's no reason to go through this in a step-by-step fashion. We now know better. So now implementation teams are plugged into all of these levels simultaneously. So yes, practitioners are being trained, while at the same time, organizations and systems are being helped to be more ready to support practitioners doing this work. You're helping them create the changes that need to be there. And we think this needs to go all the way to federal and national kind of levels as well. It's harder to get access there, but it's possible. But this is the difference between the 14% and the 14% success in 17 years, where you try to piecemeal this, and you can see any attempt to do just one of these things is not going to get you very far. Every one of these has ripples in every other direction. So plugging this in where implementation teams are working simultaneously at this alignment of things, so all of these ways of work in organizations and systems get aligned with the new innovations that you want to see happening. Lesson number 5, implementation practice leads implementation science. We can only evaluate what we do. This is a very important point for all of you. Many of you here are the future researchers and current researchers in the implementation field. But keep in mind, we can only evaluate what we do. Why did we find so much data on things that didn't work back in 2005 when we were doing the review of the literature? Because prior to 2005, people were doing again and again things that didn't work. That's what they were doing in practice. What was being done in practice is what we all were evaluating. So to change this around, we need to make use of these effective implementation strategies in practice so that we can evaluate them in practice. Very important. So this is where practice and policy, or practice and research really go hand in hand. Some examples. Here's some data from a county in North Carolina. The entire county child welfare system was being changed. You'll recognize the implementation drivers down the side there: selection, training, coaching, performance assessment, so on. We now have ways to assess these things in practice. You'll notice at time 1, and this is on a scale of 0, 1, 2, not too sophisticated, but adequate. Not in place all the way to fully in place. So you see the composite score about 1.1, partially in place, and fidelity about 18%. But as the scores, as the implementation team there did better at each of these implementation drivers, and the composite score went up above 1.5, 1.68, 1.83, you see fidelity also going up. But this research here could not be possible if we didn't have a way of producing an implementation team that could make good use of those implementation drivers. I see furrowed brows here and there. So we'll go one more. Here's another study. MST, multisystemic therapy, and ARC, which is availability, responsiveness, continuity, which Charlie Glisson and his group have put together. But here are 2 evidence-based programs that are well supported by implementation teams coming together to do some absolutely stunning research. This is the only study of its kind in the world. So here we have MST done in some counties and not done in other counties. We have the ARC approach, which again is more on the organizational side and the leadership side of the implementation triangle. And in some counties, they were doing ARC and others not. And you see that the best outcomes occurred when all of those things were being done. You had multisystemic therapy for delinquent kids being done in the context of a county organization and system that has been changed. The worst outcomes, of course, down in the corner. But think about this. These are 14 counties in Appalachia that were randomized to these 4 conditions. But to produce this, and notice that all of this was done in 4 years. So to produce this little 2x2 chart and to do this study, 2x2 factorial, this means that you have to have people who know how to do MST. You have to have an implementation team that can produce MST treatment teams, one after the other, in this county and this county, but not those counties. And you also have to have an implementation team that can reliably produce ARC in these counties and not the other counties. So here, when implementation practice gets to be this sophisticated, then implementation research can be this sophisticated. This study could not have been done 10 years ago because neither one of them had the implementation teams to support doing this kind of research. To be able to produce this outcome for each of these evidence-based approaches on purpose, in a timely way, is quite remarkable. And then to see the combination of those, fantastic. So kudos to them. So let's look at enabling context. Capacity in implementation science, in all of our sciences, is really about what people are, what do they know, what are they able to do? So knowledge, skill, ability that's embedded in these, in position descriptions, in organizations, in systems. So it's not like some people want to, are we getting close? We are. Okay. It's not like you can increase your computing capacity by buying new hardware, new software. Once you have it bought, it's there. You can combine it and you can rely on it. Here, capacity is what people are able to do. So for creating enabling context, organizations, systems that function differently in support of innovations that are effective, Here are the things that are very clear. You cannot change everything at once. We have looked and looked and looked to see where is it that a whole state, a whole country, in maybe the World Health Organization or World Bank context, where is it that they have gone in and changed everything at once? And there is no example. So, because the issues overwhelm you, as soon as you get started, everything piles on you, and the whole thing may sputter along for a few years, but it will not go and does not go anywhere. So, the complexity of it all, the enormity of it all is too much. The difficulty in human services is, unlike manufacturing, we can't stop everything and retool. We can't say, you know, all you kids who are here in school, don't come back to school until next year, because we're going to take this year to have all of our teachers go through training. We're going to do some coaching. We're going to get the schools reorganized. So you skip 2014. We'll see you in 2015. Not going to happen. You're not going to close down your public health clinics. So everything that is being developed new has to be developed in the context of continuing to do what we've always done. So that presents all kinds of very interesting challenges. We also have no idea, really, what to do at every step. People tell us all the time, here in our fill-in-the-blank clinic, school, district, we are completely unique. And we have come to believe exactly that. They are completely unique. So what do you do then when you get into this situation? How can you bring about change? How can you help them make good use of innovations under those circumstances? And this is where the improvement cycles really come into play. And many outcomes are unpredictable. Many times we have done things, we think, oh my God, how did we ever do that? And it turned out beautifully. And other times we do things on purpose thinking this is the most wonderful thing we have ever done, and it just falls apart. So you don't know. But again, you have to get into this in order to start figuring it out. So given this as a backdrop, here is the secret to success. So you guys will now be able to go and do this, and you'll be successful for the rest of your lives, just so you know. And this applies everywhere, kind of at every level. Right now, what we have is here. We have policymakers, administrators saying to us, we want you practitioners to make use of innovations to benefit children, families, adults, whoever it is that you're working with, the recipients of your services. So that's standard. The successes and the failures both have this in common. So pay attention. The first thing that happens is that an external, and externals in quotes for a reason, and we may have time to talk about that, system change support comes in, but notice what comes in with them is the implementation team. So the very first thing that has to happen is that the implementation team, as we saw, can generate 80% success in about 3 years. They start working to produce a great example of what this innovation in practice will look like and what kind of results it can produce. Why do we need this external support? Ashby, we love this quote, "The fault cannot lie in the part responsible for the repair." So this is back in the old cybernetics and days, but we think it's absolutely true. That people who are enmeshed and embedded in a system have a hard time imagining life that's different than this thing in which they've been schooled. So having this outside perspective brought in, we can go into state systems, education systems, child welfare systems, and within a few meetings have a pretty good idea of where it is they need to start doing their work differently. But if you ask people inside the system about those same things, they don't see that at all. So you have to have the external perspective. So that's where things go. And if you can't generate this part at the bottom, where the implementation team is actually doing the work of implementation to produce the best possible outcomes, or at least improved outcomes for the recipients, you might as well stop there. But that is the first demonstration. Now watch what happens. This, though, is insufficient. We have seen now examples in systems where they've taken it this far, and again, it is not sustainable. And it's not sustainable for this reason. So the last piece of this is that we need information from the practice level going right back to the people who said, we want this to be different. We are enabling you with our policies and our funding strategies to do your work differently at the practice level. But now the practice level has to speak back to those folks and say, you know, here are the 2 or 3 things that are in place that are very helpful, and here are the 2 or 3 things that really need to change if in fact we're to do this work. It is getting in our way. This set of rules, regulations, what have you, this set of criteria for funding these are not helpful. So but it has to go to the policymakers, and notice it goes around the bureaucracy. So it's the implementation team and anybody that they bring along who's going back to the state superintendent of the schools, going back to the head of child welfare, going back to the health leader for the state to say, here are the things that are getting in the way. Because you want people there who have the authority, the power, the ability to make the kind of changes that you want to see made. Because what this does, it exposes faulty assumptions. It exposes errors in the system. And as you're making changes, the system is, and people involved in the system don't sit there idly and say, oh, isn't this interesting? They come over and hit you over the head with a stick. So they're not happy about this because you're messing around with their livelihood. You're messing around with the way they have done things in the past. So you're inviting the system to respond, because that then becomes part of what you also have to work on. And the result of that then is systems change. So this practice policy communication loop is now embedded in everything we do. And again, it's within an organization, it's within a region, it's within a state, and we are now doing this also at a federal level. The thing is, we also need to have measures of things. So here is a state and regional capacity assessment, brief set of items that we have developed over the last several years. State management team, so the executive leadership of the state system, system alignment, regional implementation team functioning. You can see the changes that have occurred over the last 3 administrations with that. So we have a way now of saying, here's where we are on each of the items in this, here are the actionable ones that we can build in to make things better. The same thing in school districts. Here's one district, and here's the action planning that went on there. Here's another district. Notice how different they are. They all say they're unique, and like I say, we now believe them. But we have a way now of assessing these things and getting the information back. So why are we doing this? We're to that point. A few years ago, I guess more than a few now, in the 90s, Home Builders Program and child welfare was the latest thing. It was demonstrated to be effective. The federal government then invested $500 million into national support for the use of home builders across the country. So a lot of funding was distributed in the typical ways that the federal government does. The national evaluation of this, done by the Chapin Hall Center, showed that the program, Home Builders, was not effective. But they also, thank goodness, went a little deeper, and they did interviews to find out how were people using home builders. And surprisingly, about 25% of the funds that were spent out of this $500 million were actually used for in-office support for parents. And so let's see, home builders, home-based, go to the family in their home, work with them there, and the money was spent in the office. So I don't know if there's something that's less than zero fidelity to something, but you know, this is like antithetical. So a big chunk of the cash went there. But this implementation failure was labeled as an intervention failure, and it's taken home builders about 20 years to recover from that. Right now, federal government, our tax money, we're spending $100 billion on innovative programs in the Department of Education, $63 billion for the maternal health programs in USAID, $4 billion for home visiting programs and administration for children and families, child welfare, and no money is set aside in any of these for implementation supports. All the money is there is to support the use of these innovations. So what do we have? We're just doing more of the same with a lot more money than we had before and expecting different results. Keep on doing what you've been doing and, well, you know how that goes. Here's a final example. For those of you who can't see, this starts in 1971 through 2012. These are the National Assessment of Education Progress. This is literacy results for children age 9, 13, and 17. Age 9 is about third grade. And in third grade is where teachers stop teaching reading and they start teaching subjects based on the hope that the students know how to read. So age 9 is a critical point. But if you were to look at about 215, and this is on a, look up at the top, a 500-point scale, this has not changed. So you think for over 40 years, we have an education system, despite all of the changes in policy, the reform efforts, the No Child Left Behind, the hundreds of billions of dollars that have been invested in this in the last 15, 20 years, still no change in the outcome. Very important. The U.S. Department of Education itself didn't even exist as a cabinet-level position until 1980. So even that had no real impact. So why do we need to do this? We're really hoping that the next time we look at this, what we're going to see is that people are paying attention to that middle box in the formula for success. We're going to start funding implementation work as these are rolled out, and hopefully we're going to get a much different result. Our advice to the policymakers is that anytime you're funding an innovation, set aside 15% of the funds. We just made that number up, so there's no magic to it. Set aside 15% of the funds to fund implementation supports for the innovation. That's number one. The second thing is require regular reports of fidelity at the service level. And if you were to do those two things at a policy level, before long, we would start generating enough information, we think, to start moving this line in a pretty dramatic way. So, finally, just a fundamental truth. People cannot benefit from innovations they do not experience. So we can have the best list of evidence-based practices in the world. What if it were perfectly 100% successful every time? If we cannot get this into practice, if people are not exposed to it, it will not produce benefits. As we said before, there's now sufficient information to have all of this work. We are on the verge of creating a virtuous circle. We borrowed that from the World Bank. But evidence, as we said before, implementation practice leads implementation science. We now have enough good implementation practices going on in enough fields to generate better science, and that better science is going to feed into guiding better practices, and now we're going to have a virtuous circle that's going to take it. And this probably will not take all that long. I'm guessing 10, 15 years. I told Leah she's going to have to come visit me in the old folks' home and kind of remind me why I was so gung-ho on this stuff and show me that those NAEP data that are going up. But I think we are on the verge of this. So the last thing is, let's get to work on this. So thank you very much.
Thank you so much, Professor Fixsen, for a wonderful talk. We have time for maybe 2 or 3 questions. So if you have questions or comments, please. And maybe I'll take the prerogative and ask the first one.
Oh, please.
I love the concept of the implementation to be sort of self-aware that they're on the team. Like in HIV, we tend to call that team case managers or peer navigators, but we don't sort of label it as such. And I'm wondering what you think about the importance of that. And I'm going to put the microphone on the stand.
Yes. An excellent question, because this is one that shows up again and again now. Since we have started presenting these kinds of data to audiences, and we do a lot of work in state systems, the idea of an implementation team has kind of caught on. But the substance of an implementation team has not caught on. So people are taking some group that they already have that's doing something or another, and they're saying, oh, this is our implementation team. But an implementation team really is defined here. These are people who are skilled, they are experts really at these functions that are here, operationalizing interventions, doing the work of implementation, helping with the organization change part of things. So they have special, just like an IT department or your finance group, you're not just getting anybody in there, you're getting people with, the skills and abilities. Now, having said that, the difficulty is there are probably maybe 100 actual implementation teams in the entire world, and many of them are in Norway, where they started this work 12 years ago. So but it's coming along. But rather than saying we're going to call anything an implementation team, we really want you to stick with this operational definition of what an implementation team is and work to develop them. This is really our work in implementation, or in the scaling up work we're doing in education and child welfare and early education for children. So. You can also shout out a question, and I can repeat it.
The problem with shouting out is then it's not on the podcast.
Yeah, well, I can also repeat them, but yes, I get you.
Yeah, so I really learned a lot and enjoyed your talk. One of the points you made was the importance of the fidelity of the intervention. But it seems to me whenever I've been involved with taking something that was developed in a research setting to a practice setting, the first discussion is always about what can we get away with not doing? How do we take this thing that was done in a very expensive, resource-rich environment and transport it to a lower resource environment?
That's an excellent question, and a really tough set of conditions. But this is where the usable intervention criteria come in. So what can we get by with? I like that, because one of the things that we talk about, what's barely adequate? We're not looking to have the ideal. We're not looking to have, some $1 million, per customer kind of approach. What is barely adequate? But that's where the usable intervention criteria come in. So what is barely adequate is when we have those functions operationalized, and when we are assessing those functions in practice, we have a good high relationship between doing this and getting that. We have bumped into people said, well, we have high fidelity and we still get poor outcomes. And saying, well, in that case, fidelity is not important. Well, no, either you don't have, if you have high fidelity for an intervention, maybe you need to think about changing interventions, because that intervention probably was not effective in the first place. So you're right into the middle of a big debate that's going on. Adopt to adapt, adapt to adopt. Yes, that's it. Adapt to adopt is kind of a little phrase that gets repeated again and again. This intervention doesn't fit in our program here. This 12 steps, it's too many steps. We're just going to use 6, because that's all we have the time and resources for. The 90 minutes that you're supposed to have for literacy training for kids in the early grades, that doesn't fit our school schedule. So we're only going to do 45 minutes. So now, if you do the 45 minutes, if you do the 6 steps, and you're still getting great outcomes, now we're on our way. You don't need all 12, you only need 6. But we are all about measuring the outcomes and seeing where in this can you find that sweet spot where you have enough of it to produce the outcome that you want and to get you started down the path. But so many people fool around with the intervention before they've even tried it. So our advice is always do it as intended first, look at the outcomes, then start working on revision. But if you do it as intended, you look at the outcomes are good, chances are by then you will be convinced that, we like these outcomes. Maybe we need to change the rest of this. There's a reluctance on the part of organizations and systems to change, to accommodate, to become a hospitable, enabling environment for innovations. They want it to be all about the practitioner, not about me, the manager. I'm sorry, yes.
Well, I think that we're unfortunately right about at time, but it's been a great discussion, and I know that Professor Fixsen has a few more minutes that if you have questions to come up front and chat one-on-one for a few moments would be great. And please join me in thanking Dr. Fixsen for a
And
wonderful
thank you all very much.